now going to talk about patient navigation and really, how that can support a patient's journey. And so we have Messina Corder. She's an experienced leader with a diverse clinical and administrative background in acute and outpatient oncology services, data and accreditation, and research. And she holds a master's degree in business administration and a Bachelor of Science in nursing. And then she will be joined by Carol Logan Thompson. And Carol has worked in the field of nursing for 45 years. 44 of those years have been spent caring for oncology patients. And she's worked in a variety of roles throughout her career, such as staff oncology nurse, head oncology nurse, clinical nurse specialist for oncology, and assistant professor at Western Carolina University. And most recently, she's a thoracic nurse navigator for the past 8 years. So I am going to turn it over to Carol and Messina.
All right, thank you so much, Paige. And I am going to pull up some slides that we prepared. All right, well, thanks everyone. As Paige mentioned, my name is Messina. I'm the director for our oncology nurse navigator program at Mission Health, and my colleague Carol is going to be joining me as well. So thank you for inviting us. It's an honor to be a part of this summit. I'm just going to start off just talking a little bit about where we work, and then Carol's going to get to the very important part of this presentation about actually what lung navigators do and their role in advocating for patients. So let me just make this a slideshow. There we go. All right. This is Mission Health. We are located in Western North Carolina. We have about seven acute care hospitals, and Mission Hospital is right there in the center in Asheville. That's our main hospital. And on that campus is where Carol and I live at the Mission Cancer Center. You can see it there in the top picture. And just a few miles down the road, that bottom picture is our Women's Cancer Center. And we've been so inspired today by all the speakers so far. And the White Ribbon Project was amazing. So we have put in our request to get our white ribbon, sorry, I can't say that today, for Mission. So we're looking forward to being a part of that. And I just to kind of see, you'll see the Sarah Cannon logo there. So Mission is part of the HCA health system, which has hospitals across the country. And our oncology program is actually called the Sarah Cannon Cancer Institute. So why is it called Sarah Cannon? Some of you may have known the radio and TV personality Minnie Pearl that was on the Grand Ole Opry a lot. So Minnie Pearl's real name was Sarah Cannon, and she received treatment for breast cancer actually at the Founding Hospital in Nashville, Tennessee. And so she offered the use of her name to continue to promote cancer care and cancer research. So that is why you will see that Sarah Cannon name for our cancer program at Mission. I just wanted to give you a little background. So one of the amazing services that we are able to offer through the Sarah Cannon Cancer Institute is our navigation program. So across the country, we have about 200 nurse navigators that are in about 110 hospitals. And we navigate over 90,000 patients, and about 1,500 of those patients are navigated here at Mission. So this is our amazing nurse navigator team that we have. We have 8 navigators, and Carol, as you're going to hear talk in just a few minutes, she focuses on lung cancer. We also support patients with breast cancer, GI cancers, GYN cancers, head and neck, neurologic, and sarcomas. So we just truly believe that, and we want to expand because we believe that every patient should have a navigator, because we believe that this role is just a key part of helping our patients and their families navigate the complexities of the healthcare system, to have an advocate, and to remove those barriers to care so that our patients can focus on completing their treatment and getting well. So that's us in a nutshell. And so I'm going to turn it over to Carol so she can tell you more about the navigator role and what we do to advocate for patients. All right, Carol.
Yes, well, thank you to the LCI for inviting us both to be here. We really appreciate this opportunity. And I'm not going to spend a whole lot of time reiterating what she said about me, but I am just so excited to be here. I have loved this role of a navigator the most of all the roles I've held. So it's a real opportunity to be able to do this, and a blessing. So just to start, when I meet a patient initially in my navigator role, the first thing I do is just introduce myself and what the role entails. And it's usually met with some humor with the patients because most of them have not heard the role of navigator. So it usually ends up being a really great icebreaker. What are you navigating exactly? So I get an opportunity to discuss the role. The other thing I really like to do when I first meet a patient, so that I can advocate for them appropriately, I just start assessing from the very beginning, what is their support system? Who's with them today? Because that's going to make such a big impact on their workup and their future treatment outcomes. So that's a big part just in the beginning. I like to divide the navigator role into two big categories, and other navigators may look at things a little differently. So, I'm not the end all with this, but this is just something I see as part of my role and what's helpful for me. But I see that our role as a navigator is very important in advocating for the patient's voice and the development of a treatment plan for these patients, because it is their diagnosis. It is them that's having to go through all these appointments and workup and these treatment plans, not me and not the doctor, not the other providers. Certainly we're engaged in it and we're trying to facilitate it, but it's their plans. I want to make sure they are the focus of this, because that's important. The other thing that I, as a navigator and other navigators do, is that we assess for barriers and provide support. And I would say that assessing for barriers, that's the big buzzword for navigation. They all want to hear what we're doing with barriers. I've listed, I think, the most common barriers to care on this slide, but I'm going to introduce in each of these individually in just a moment. So I won't read those to you right now. So if you'll go to the next slide, thank you. One of I think the biggest things that we deal with is coordination of care. So, I don't know how many patients are on the call, or former patients, people in treatment, family members. Most patients are going through something in the very beginning. Maybe they're having shortness of breath, or they're having this cough that won't go away. And so, they put off some time seeing if that won't get better, or maybe their primary care provider sees them several times and they have bronchitis or they have allergies. So eventually they get chest x-rays and CTs, and okay, now we have an abnormal result. What are we going to do now? They end up being referred to pulmonary. Pulmonary is probably going to order a PET scan. So there's additional appointments. It's like you get one appointment and then there's another one, and then there's another test to undergo. From the PET, okay, now we can see, what do we need to biopsy? What kind of biopsy do we need to do? Is it a CT guided? Is it a NAVI, an EBUS? So there's a whole alphabet of biopsy techniques out there. So again, more appointments and more wait times as well. Next, once that pathology's back, then we've got to go back to pulmonary, or at least talk to someone on the phone. What do we do next? What type of providers do we go to now? Do we go to medical or radiation oncology or to surgery? So there are so many appointments, so much to keep up with. And during this workup that people get so overwhelmed. Now, if there's navigators in place that can help with this, one of the things we can do is make sure that the appointments happen timely, so there's not long delays in between those workup appointments, that we can help getting results to patients. I don't know how many times I've heard patients say, oh, I waited a week to get my path report, or I waited a week to get that PET report. And that is so anxiety provoking. You don't know what it showed. You're imagining the worst, and what does this mean for me? So if we can help facilitate getting those results to patients. The other thing is maybe working with your pulmonologist to help expedite referrals to those treatment providers. So again, that there won't be long delays. And I think this is extremely important just for the psychosocial needs of the patient, but also so that we get treatment started more timely, because we know it makes a difference that we get people to treatment sooner. I know with Sarah Cannon, they say once you have your diagnosis, they'd like you to have you in treatment within 30 days. So I think coordination of care here is a big role for navigation and to try to assist patients. Next slide. So one of the barriers I've identified, or I'm sure everybody's aware of, is education. So you have a biopsy planned. Lots of times if people don't know what's involved with that biopsy or why it's being done or how it's being done, sometimes they cancel it or they're so terribly fearful of it, before they go, that they've wasted a lot of energy that maybe they didn't need to because they just didn't understand it. So if education can be offered for all of these workups that they're having done, and then certainly, of course, when they're getting ready to undergo treatment, education about their chemo or their immunotherapy or about their surgery, it's just imperative. That education could be verbal, it can be handouts, it can be websites you send them to, certainly can be our organizations like Lung Cancer Initiative websites that have information. Pharmaceutical resources, NCCN guidelines, the American Cancer Society. There's lots of ways we can utilize education to make this process easier for them so that they understand what's happening to them. That way they can use their voice and, to speak up. And I encourage people to ask questions. If you don't know what you're having done, you don't know what it's for, where I'm going, certainly speak up. Next slide. Psychosocial, another barrier. And again, I'm not putting these in any sort of order. They're all important. And some patients are going to have one barrier that stands out more than another, one thing that bothers them more than another. So this is very variable, but it is just one of the barriers that we need to assess for. Again, it needs to be patient-centered. What is the patient identifying as their biggest concerns? Not what I think their concerns are or the doctor thinks they are, but what are their concerns? And you can certainly involve their support system. What are they seeing as some of the big issues for them? So we do want to identify the support systems that they have so that we can pull them into the care plan, and that's very important. We want to be able to talk about these concerns, make them feel comfortable talking and not feel judged about concerns they have or things that they don't know is very important. I think the navigator can really be a good point of contact. We make sure they have our number, our email, can text us, many ways of communication so that if they have questions or they don't know where they're going or why they're going or why that's being done, they can call us and ask us. And I think we can be like a good pivotal point. I think we also have that 6,000-foot view that we can see the whole treatment plan. Or if we can't find the answers, then we know where to go to for them. I think that's important. Certainly we make referrals to support services. That might be an LCSW, a chaplain, palliative care, support groups. Unfortunately, due to the pandemic, haven't had any of our inpatient or face-to-face support groups, but thank goodness to organizations like the LCI, there have been many Zoom support groups that people could still participate in. Other support services might be referral to palliative care for symptom management, or maybe even hospice for some patients. So one thing I know, working with the Lung Cancer Initiative, they were working even on a peer-to-peer support system. And I've utilized that many times with patients if they've wanted to talk to someone else going through something similar to them. Financial, thank you, Messina. Okay, here's a huge one, huge. We all know how expensive cancer care is. I mean, it's very expensive. And I keep saying the first thing I do, but I want to back up just a minute. One thing I do before I ever meet a patient is I do look at their demographics. And that's not because I get paid or any remuneration for my services, but I want to see if people have insurance. Because if I'm meeting somebody that's uninsured, oh my heavens, they have so many barriers just from the outset. And so I want to find out, are they someone we should refer to Medicaid, to apply for Medicaid? Should we refer them to the Social Security Administration for disability or to the marketplace to get insurance? What can we do for this individual to try to get them some health care coverage? Certainly, we have ideas about grants we could refer people to, patient assistance programs, and medication assistance programs as well to try to decrease some of this financial burden. If you have a financial counselor or financial navigator in your area, and I should say, if whenever you first get diagnosed or you're first being faced with this workup, I would ask, is there a navigator I can see or meet with? Because I feel like that's something you can ask for, and would be wonderful that if you have a navigator in your court. You can also ask about a financial navigator and see if someone, because they do have a broad breadth of knowledge about all financial issues that maybe I don't have. I mean, I have to do lots of research and involve other folks. It's not my full-time job, but I have learned so much through this role that I feel like I am able to help to a good extent. There's other specialty programs over here on the side. For instance, your community may have things. We have Asheville and Buncombe County have the Asheville-Buncombe Community Christian Ministry, for instance, that has a pharmacy for free meds. They have a warehouse for all kinds of DME equipment like rollators and walkers, things like that. There's cancercare.org that you can refer people to for financial assistance. I've had patients who were still working that were really Medicare age, but they had not actually applied for Medicare because they were still receiving a paycheck. They maybe only had Medicare A. So our Council on Aging, and I know we have those throughout North Carolina in each county, ours is amazing. They do a fantastic job of educating people for Medicare and all the parameters of that, whether regular A, B supplements and D, or whether it's an Advantage plan, and they can really help people process what's best for them. So that's a really good resource. Salvation Army, United Way, and I'm sure there's so many more I'm not mentioning here. I do want to mention Triage Cancer. If you're not familiar with it, that's a website you can go to, and it's a great organization that can help individuals with financial questions and concerns. They have great resources. They also have really good programs for professionals to attend for learning purposes. And not only do they help with financial barriers, they also help with legal and practical issues as well. Next slide. All right, transportation, another barrier. When I read the literature, I think they say that like 60% of patients with cancer have transportation barriers. So we certainly have those as well. And here in Western North Carolina, we have a huge rural area. So we really can have some transportation issues. So when I first meet that patient, who is there with them? Is that support person somebody that can help with transportation, or do they know other family that can help? And certainly I try to engage the patient. Who do they know? Who's in their network, their church, family, friends, neighbors? Who can they enlist to help? And try to do that first. And if there's not the resources there, then certainly we have to look to others. Like our Asheville and Buncombe County have a program called Mountain Mobility. And it's a transportation service. It's a van. They might take several people at one time. A little bit of downside in that there is some wait times on either end of your appointments, but oftentimes people can use that to advantage. They can learn, they can talk to people on the van and have some outside contact that way. So there's road to recovery. If a patient has Medicaid transportation is available for those people. They can either arrange for transportation, or they can voucher gas for them. It's a loved one or a significant other one is taking them to their appointments. I will say one thing, and I'm not sure how much time, I got a few more minutes. One thing I learned doing this role is if you see somebody has Medicare as their primary, but then Medicaid is second, you do want to check with their Medicaid caseworker. Are they really eligible for Medicaid transportation? You don't necessarily want to promise that, because that Medicaid may just be paying their Medicare premium. So it's always good to call the caseworkers, and they're very helpful to answer those questions for you. Certainly there's public transportation like bus lines, Sometimes we can even get vouchers for buses. One thing I really try to advocate for is if people are thinking about riding the bus, is to tell them where the drop off and the pickup is here close to the cancer center, because there are two different places. And if somebody has to be able to walk to do it, it's not like right out the door. Other transportation resources might be like if they live in an assisted living. And I would be remiss if I did not mention the Lung Cancer Institute. We are so appreciative of your gas cards. You just don't know. I meet a patient and we're talking about transportation, and I'll say, well, would you like a $50 gas card for the Lung Cancer Initiative? And people just brighten up. It's just, you should see the smiles in their eyes. It's just really funny that they're really excited to get that $50 gas card. So thank you so much for providing those. Trying to think, oh, I did not mention American Cancer Society. I'll be so glad when the COVID era has passed and hopefully the American Cancer Society can open up their Road to Recovery program again, because that was really invaluable for us, where they had an individual volunteer bring them to their appointments. And we have had some great volunteers in this area. I mean, I would have, like, they would develop a relationship with this patient and then they would sign up for all their rides, you know, so they really got to know that individual well. And ACS even had a ride share program where they could provide, if they couldn't get volunteers, they could provide up to 10 things like Uber or Lyft to bring the patients to their appointments. And people could certainly pay for that too if they have the financial means to do so. All right, now next slide. So there's other things I think we need to take into account, and these I think we should pretty much all be aware of already, are some types of sensory deficits. Certainly if people have language deficits, they don't speak English, we need to make sure there's translators available, translator services. Maybe we need larger print. Maybe better, you know, somebody else just to listen in, have a support person there with them, helping them comprehend. Also hearing. I don't know how many times I've sat with patients and they sat through the entire consult and you thought, I mean, you just didn't identify that they were not hearing until later, that they didn't hear any of that discussion. Many times they do have a caregiver there with them that's hearing it, and that's why they're there. So here in our cancer center, the radiation therapy department has this hearing aid device. I wish we had them in all our departments, but this one fella, his wife let us know right away that he couldn't hear it thunder. And of course he would get embarrassed because she said that. So anyway, that first day that I found that out, I went running to radiation therapy, borrowed their device, and he put that on his head. And he smiled. He was like so excited that he could actually hear this consult himself, because he was pretty much just relying on whatever his family told him was said. So from then on, for the if he was seeing the medical oncologist or he was in infusion, I would get that just assistive device for him so he could hear what was going on. And so eventually they bought their own off of Amazon Prime. So anyway, that was a big plus for him. Vision is another potential barrier. I won't go into that in detail. One thing I do want to bring up, I think that we need to advocate for patients. I mean, and all of these barriers are so that we can advocate for patients and families. But child, family, and elder care needs. I mean, I've had so many young people diagnosed with lung cancer, and they still have children at home. And this last year has been really, really difficult. If these kids were on Zoom doing education, so they're having to help even more so with their education. If they were trying to go to school, you know, like 2 days a week, then how do they manage that and manage their treatment? Also getting them to after school activities. So you just really need to advocate, make sure appointments work well for them so that they can be a parent, like, and carry on some of their normal life like they would like to do so. Same thing for elder care needs. A lot of patients are taking care of mother or dad or maybe grandparents, and they're dependent on them for their care needs. So what can we do about that? Is there some kind of adult daycare that could help out? And on several instances, we've had to have some family care meetings where we brought the siblings, all of the extended family in, because nobody had really been stepping up to the plate but this patient. And so we would bring this so we could talk about it in the open, what this patient needs to help. They need help to get through this. Sometimes those were very successful, sometimes not as successful, but it did get it out there and the patient's needs, were discussed. So I think, okay, my last slide, thank you. So this is a patient who just finished therapy last week, and he's become near and dear to my heart. He has non-small cell lung cancer. It was very locally advanced, actually growing into the atrium. And he had been working just a few weeks before treatment. Excuse me. And so had to quit working as a painter, didn't have anything like short-term disability, too short of breath and too high flow of oxygen to be able to drive himself. So we referred him, he was old enough to apply for Medicare, so we worked on that. We were able to get Medicaid for him. We got mountain mobility for transportation. So there were just many barriers we were able to work with for this individual. He lives alone. His closest family's in Colorado, but we have been in communication with them, and they've been sending monies to help also with finances. One other interesting thing, and I know I need to stop, is the last thing. A little bit over 2 weeks into his treatment, one of his drivers of the mobility van came down with COVID. And so he got a call on a Wednesday morning that we're going to you need to stay on 14 days. Oh gosh, I can't even think of the word. Quarantine, thank you. I need my prevision. Quarantine, and you have to have a negative COVID test before you can come back and ride on mountain mobility. Well, that was just not going to happen. He couldn't take 2 weeks off from treatment, not at all. And so I worked closely with Mountain Mobility and actually called the Buncombe County and Raleigh Department of Health and Human Services. And so they ended up being able to send an individual to each of these people's homes that were affected to do the test in their home. And they were able to get the results back by the following Monday, so people were able to resume their rides. So anyway, I learned a lot taking care of this individual. So again, thank you for the opportunity to speak. Sorry I've rattled on so long, but thank you for letting me be here.
Carol and Messina, thank you both so much. It's really wonderful to hear all of the things that you're doing at Mission Health to support your patients. And I hope it's helpful for everyone else here to hear what type of support you should be advocating for. Everyone deserves this level of care and support in navigating lung cancer because it's such an overwhelming experience, especially at the beginning. We have time for one quick question. Someone asked, at what point do you as a nurse navigator get involved? Is it at, the low-dose CT scan or the chest x-ray, or after you've confirmed the lung cancer diagnosis?
Well, with Sarah Cannon, their program is from diagnosis forward. In my past, I have worked with the lung screening program, and I know my boss is on here, but but I do get some calls from pulmonary asking if I can reach out to some people during the diagnostic workup because they're having such a difficult time and I don't like the word compliant, but they'll say they're having difficulty with compliance, and can I help with education and support needs? So primarily, I'm supposed to be focused on diagnosis, but there are a few others that sneak in there.
Awesome. Well, thank you so much. And I think now it's time for a little bit of a break. So everybody, I encourage you to get up, stretch your legs, get something to drink, maybe a snack. Our break is going to be 15 minutes. And so at 2:15, we'll meet you back here. And we'll be hearing from our next speaker, Kara, talking about how to share your story and advocate for lung cancer.